Welcome to today's webinar, Infectious Vulvovaginitis, Etiology, Epidemiology, Diagnosis, and Treatment, which is part one of ARHP's two-part webinar series on vulvovaginitis. I'm Melissa Werner, Director of Education at ARHP, and it's my pleasure to serve as moderator today. To receive continuing education credit for this activity, you must take the pre and post tests. If you have not taken the pre-test and you are viewing this webinar live, you will find the pre-test link in your reminder email. The post-test link will be sent to you after the webinar. If you are viewing this webinar on demand, both the pre and post-test links can be found below this video. In the webinar dashboard, you should see a chat box that you can use to enter questions throughout the webinar, which our faculty will answer towards the end of the webinar. In 4 weeks, you will receive an email from ARHP's Education Department with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you have incorporated what you have learned during the webinar into your work. Completing the pre and post tests as well as this follow-up evaluation helps ARHP ensure we continue to meet your educational needs and interests, and we thank you in advance for your time and feedback. Before we get started, ARHP would like to acknowledge that today's webinar was made possible through an independent educational grant from Symbiomics. And as you can see from this slide, none of the members of our planning committee for this program have any financial relationships with commercial interests to disclose. We sincerely hope that by the end of today's webinar, you will be able to do the following with respect to infectious vulvovaginitis: summarize the epidemiology, describe the diagnostic process, discuss the elements of effective patient education and counseling, and list currently available treatments and treatments in development. Our presenters today are two wonderful people that we've recruited for their expertise on this topic. Tosin Goji, MD, MSCR, and FACOG is an assistant professor of surgery at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University and staff in the Obstetrics, Gynecology, and Women's Health Institute at the Cleveland Clinic, where she leads the Gynecologic Infectious Diseases and Vulvar and Vaginal Disorders Center. She is on the ACOG Committee on Gynecological Practice and has published journal articles, book chapters, and internet-based educational resources on reproductive infectious disease. She is also a contributor to online physician resources and is actively involved in training and mentoring of medical students and residents. Our second faculty member is Ruth Merkatz, who is a PhD RN, FAAN, and is Director of Clinical Development for the Population Council's Reproductive Health Program, and co-oversees the clinical work for the Council's contraceptive vaginal ring program and other contraceptive formulations in development. She has an appointment as clinical professor in the Department of Obstetrics and Gynecology and Women's Health at the Albert Einstein College of Medicine, where she serves as the research advisor for the Family Planning Fellowship Program. We're thrilled to have these two experts with us today, and without further ado, I'll turn the webinar over to Ruth.
Hello, everyone. We're about to spend the next hour discussing vulvovaginitis, a hot, literally burning, if not irritating topic. Commonly known as vaginitis, it is responsible for more visits, phone calls, text messages, or other forms of communication to healthcare providers than almost any other condition. But for a woman, it can be especially scary, especially if they have not had this experience before. So we're going to spend the next hour trying to clarify aspects of the most common forms of vaginitis that serve as a guide, perhaps, as you care for your patients and get more involved in this important women's health topic. The classical symptoms, as you probably know and have experienced: vaginal itching, discharge, odor, irritation, or burning cessation, and caused by bacterial, fungal, or parasitic infections. It may be related to low estrogen or an allergic or irritation response. So the potential causes are many, and there is often underdiagnosis of this condition, as women may be embarrassed and may not seek help, or they may lack access and begin to self-treat at times inappropriately, since there are so many treatments sold over the counter. The diagnosis and treatment of vaginitis is also a topic that some healthcare providers may not be that familiar with, and so it is important to try to educate all groups of healthcare providers on this very prevalent condition that women are so likely to experience over the course of their lifetime. And many clinicians may not be aware of the symptoms or how to evaluate and interpret various diagnostic tests and results. As we all know, the costs and consequences of the vaginal infections are enormous. Not only can the cost be very high overall, but it can have adverse effects on women who are affected by vaginal infections. It can have adverse outcomes in pregnancies, especially those affected by bacterial vaginosis. Certainly there are many psychosocial problems, even depression, that could be occur when there are frequent episodes of vaginal infections. And there is the increased risk of sexually transmitted infections in association with some of the vaginal infections, or with repeated types of vaginal infections, such as BV, which we'll hear more about very soon, and especially as I turn it over now to Tolson, who will start off by discussing bacterial vaginosis. Tolson?
Thank you very much, Ruth. Hello, everyone. My name is Tolson, and I'm happy to come and discuss some of the common infectious vaginitis with us. We're going to start with bacterial vaginosis, also called BV. BV is a polymicrobial clinical syndrome resulting from replacement of the normal hydrogen peroxide producing lactobacillus to anaerobes in general. BV is the most prevalent cause of vaginal discharge or malodor that a woman will complain of to her primary care provider. However, in a nationally representative survey, most women with BV were asymptomatic. Although BV-associated bacteria can be found in male genitalia, it is not an STI, and there has not been any beneficial evidence of treating the spouse or the partner of patients with BV. Other risk factors that patients might complain of when they present with BV is low socioeconomic status, a history of drinking, smoking, having a new sexual partner, or sharing their sex toys. And also women who have sex with women have been found to also have bacterial vaginosis. The presentation and prevalence of BV. Presentation, most of the time patients will complain about copious discharge or malodorous clear discharge, which has a fishy or unpleasant smell. Sometimes they tell you the smell is worse before their period and after their menstrual period, or the smell is stronger or worse after sexual intercourse. Among women who are seeking care for BV, most of them might be asymptomatic, and it might be a diagnosis their provider finds. But in general, BV is the most common cause of vaginal discharge. Racial and ethnicity disparity occurs. We have most patients with BV being Black or African American women. The natural history of BV. The vagina has good bacteria, the lactobacillus, and then sometimes might have anaerobes like Prevotella and some mycoplasmas and Gardnerella vaginalis. 84%, as we said, will be asymptomatic, but as the lactobacillus group declines and the anaerobe group increases, patients become symptomatic. If it's untreated, long-term symptoms could occur. Other risk factors of not treating BV includes complication of after gynecologic surgery, pregnancy complication like preterm birth, preterm labor, and untreated bacterial vaginosis could increase the risk of acquiring other STIs like HIV, gonorrhea, chlamydia, or herpes. So who should be treated for BV? Symptomatic women only should be treated. We don't have enough evidence to recommend universal screening in asymptomatic women, including pregnant women. But if you have a patient who is going for a gynecologic surgery or a patient with history of preterm birth, taking a thorough history might help you decide if she should be tested or not. How do we diagnose BV? Bacterial vaginosis can be diagnosed clinically in the office using wet mount. It could be diagnosed in the lab by using the gram stain, or you could use some spot tests like the DNA probe that is readily available or the rapid test. So if we're performing a saline microscopy, after collecting a vaginal sample from the posterior fornix or the lateral vaginal wall, about 0.5 mils of normal saline should be put in the test tube that you put your swab just to make a quick preparation, or this could be made on the slide. Also, you should do a pH to see if the pH is greater than 4.5, which most of the time the BV pH is greater than 4.5. A whiff test can also be performed whereby 10% of potassium hydroxide is dropped on the slide or on the swab, and a positive amine or whiff test is perceived. Some people say it's like rotten eggs. That's the way it smells when they put the potassium hydroxide. Then you look under the microscope. If you look under times 10 power, you might see some staining, but you could switch to 40 times 40, and you see the vaginal epithelial cells that are studded with bacteria. This is what is called clue cells. Some patients might not have up to 10 or 20% of clue cells, but might have other positive criteria like the pH or the amine test. And to talk about clinical or diagnostic criteria, the commonest diagnostic criteria used in the office is the azoles criteria. So the azoles criteria involves the use of a pH, the whiff test, the clue cells, and the appearance of the vaginal discharge. So for the azoles criteria, you need 3 out of 4 to make a diagnosis of bacterial vaginosis. So it could be clue cells of 20% or greater on the wet mount, or a positive whiff test, a pH greater than 4.5, or the thin homogeneous discharge. You need 3 out of 4 to make a diagnosis of BV using the azoles criteria. The Nugent scoring system is used more in research and in the laboratory, whereby a gram stain is done at times 1,000, and you look for a weighted combination of lactobacilli, Gardnerella species, and cobs rods. And the gram stain is then scored from 0 to 10, whereby 7 to 10 is usually diagnosis of BV, 0 to 3 is normal vaginal specimen, and 4 to 6 is intermediate. The Nugent score is the gold standard, although it could be time-consuming and costly, hence used more in research. Now let's go to treatment. After your diagnosis is made, how do we treat patients? The common medications that we use are comparable, and they are metronidazole and clindamycin. Metronidazole can be taken orally twice a day for 7 days, or used as a gel, and the gel is used every day, preferably at night if the patient works during the day, daily for 5 days, or they could use the clindamycin cream, which is a 2% cream, used vaginally at night for 7 days. Other medications that could be used include tinidazole as a daily medication for 2 days or for 5 days, depending on the strength. And for patients who cannot tolerate metronidazole, the clindamycin capsule by mouth twice a day for 7 days, or the vaginal ovules for 3 days can also be used for treatment. These are the common treatments, the standard treatments we've had, and a lot of research has been going on looking for better treatments that might improve compliance or help with less reoccurrence of BV. And we have approved, as of September of 2017, secnidazole. Secnidazole is an azole antibiotic. It's a one-dose treatment used orally. So this might help with compliance because they take it once and then it continues to treat the patient and is effective as good as metronidazole for 7 days. In the pipeline is also the Lactobacillus crispatus, and that might also help by improving the pH of the vagina. It's still under trial, and hopefully more and more medications will be available to help patients who have recurrent BV. As far as BV and pregnancy is concerned, there's no evidence to screen pregnant patients. Of note, metronidazole crosses the placenta, but there's no evidence of teratogenicity or mutagenic effects. And pregnant patients should get the same dose of 500 milligrams twice a day for 7 days. But pregnant patients are encouraged to avoid tinidazole. If a woman is breastfeeding and she's diagnosed with BV, there's no adverse effect on infants based on case series, but some clinicians or experts will advise that she stops breastfeeding for 12 to 24 hours after a single dose. How do we treat patients after they have been diagnosed with BV and given the appropriate treatment? We want to counsel them that they should be tested for other STIs, including HIV. Treatment of sex partners is not recommended. And for those who have been treated, it was not effective. It didn't make any difference. Patients are encouraged to use condoms with all sexual encounters and to clean their sex toys after each use. Patients who take metronidazole or tinidazole should avoid alcohol for 24 hours after completing metronidazole or 72 hours after tinidazole. The same treatment regimen applies for both HIV and non-HIV patients. Now let's go to the next common infectious vulvovaginitis, which is candidiasis. So vulvovaginal candidiasis is one of the most reported, self-reported vaginitis. Patients will call and say, I have an itch, I think I have candidal infection. Vulvovaginal candidiasis is an overgrowth of candida. The commonest is Candida albicans, and in 10% of patients, it could be a non-albicans candida like Candida glabrata or cruzi. Normally, candida happens when there's a change in vaginal environment. And the things that could change the vaginal environment include use of antibiotics, continuous use of antibiotics, uncontrolled diabetes, a diet that is very high in refined sugars, patients with one form of immunosuppression or the other, whether it's a disease, transplant, medication, also at a higher risk of having vulvovaginal candidiasis. Of note is not a sexually transmitted infection, and there are some patients with vulvovaginal candidiasis that have no risk factor. The risk factor was not found, but they keep having vulvovaginal candidiasis. VVC presents as itching, soreness. Some patients have a white clear discharge, a white liquidy discharge, or a thick clumpy discharge that they might tell you it looks like cottage cheese. Sometimes the vulva is erythematous and they might have some fissures and erosions. Vulvovaginal candidiasis is pretty prevalent in reproductive age women. About 75% of women will have at least one episode in their lifetime, and up to 40% might have 2 or more vulvovaginal candidiasis. The natural history, it could be divided as complicated or uncomplicated vulvovaginal candidiasis. The complicated are those that have severe symptoms, a lot of itching leading to excoriation, frequent reoccurrence, non-albicans species is cultured from the vagina, or those whose immune system is compromised by health issues or medications. Vulvovaginal candidiasis is said to be uncomplicated if it's a one-time or if it clears with normal medications that is usually prescribed for yeast infection. Also of note, if it's a complicated vulvovaginal candidiasis, it might require specific treatment for that particular species and for a longer duration of time. How do we make the diagnosis? We can use a saline microscopy for wet prep. A gram stain can be done. 10% potassium hydroxide can be used. The pH should be checked. And finally, culture, which is a gold standard, should also be done. So if we do a saline microscopy, what we see sometimes by just preparing our sample is hyphae or pseudo-hyphae. Or sometimes if it's atypical candidiasis, you might see body. Some people describe it as a bowling pin appearance. If we don't see the fungal elements, addition of 10% potassium hydroxide can help to actually show more of the hyphae or the pseudo or the fungal elements. The pH in yeast infection is usually less than 4.9. And if we are in doubt that it's vulvovaginal candidiasis, a culture should be done. Fungal culture will diagnose Candida and also tell us about the species, if it's albicans or non-albicans, and if it is sensitive to the medications we have prescribed. Medications or treatments for vulvovaginal candidiasis could be over the counter, or it could be a prescription medication. Over the counter medications could be used in uncomplicated vulvovaginal candidiasis. For uncomplicated VVC, a single dose of an oral treatment or topical dose of an azole or antifungal for 1 to 3 days will suffice. If the patient has severe symptoms, the topical azole might need to be used for at least 7 to 14 days, or oral fluconazole at 150 milligrams or 200 milligrams might be needed in 2 doses given 72 hours apart, because the half-life of fluconazole is pretty long. For non-albicans vulvovaginal candidiasis, we're talking about the Candida glabrata. Our first-line fluconazole is usually not effective in 50% of the time. So the recommendation is to try and start the patients on boric acid, 600 milligrams intravaginal daily for 2 weeks. Also, there's evidence that using amphotericin B compounded vaginal suppository of 50 grams daily for 14 days might help. But patients should be counseled that amphotericin B could be irritating to the vulva, so care should be taken to insert it as high up in the vagina as possible. For patients who might be immunosuppressed, they might need up to 14 days, 7 to 14 days of topical treatment, or oral fluconazole 150 milligrams in 2 doses, 72 hours apart. And pregnant patients should be given only topical azole daily for 7 days. What are the other treatment considerations when we give patients antifungal medication? Oral azoles like the fluconazole has side effects of headache and nausea. And it's important to also look at the drug interactions with other medications the patient might be taking before giving the prescription for oral azoles like fluconazole. For the creams and the suppositories, they could weaken latex condoms and diaphragms, and also some vaginal rings. So it's important to read the drug label or the insert before using the creams with any of these contraceptive devices. Also, we should consider self-diagnosis could be wrong many times. Vulvovaginal candidiasis is one of those vaginitis that most patients self-diagnose, and there are studies out there that show that most people might misdiagnose themselves. So if the patient uses an over-the-counter medication and symptoms persist, we recommend that clinical evaluation should be done to confirm that it's not a dermatitis, but truly vulvovaginal candidiasis. In preventing recurring infection, there are studies looking at probiotics, and there are also studies looking at other new medications for recurrent vulvovaginal candidiasis. It's not a sexually transmitted infection, so treatment of partners is usually not necessary. And when patients use over-the-counter treatment, we could give them some advice or some counseling. For example, patients should use over-the-counter only if there's a previous diagnosis of candidiasis and the symptoms they have now is the same as what they had with the diagnosis. They should read labels carefully to make sure it's not interacting with other important medicines they take. And if in doubt, talk with the pharmacist. They should be aware of what type of contraceptive device they use and to know that it could weaken the strength of the latex condom, diaphragm, or the ring. Also, patients should pay attention to timing and dosage of over-the-counter medications. And if their symptoms persist despite doing all the right things, then they should call their provider and go in for evaluation to make sure it's not another form of dermatitis. Finally, we'll talk about trichomoniasis. This is our third infectious vulvovaginal candidiasis we'll be talking about. Trichomonas vaginalis is a flagellated protozoan, and this particular one is sexually transmitted. It affects both a younger and older age group, almost in a bell-shaped curve. And risk factors for Trichomonas vaginalis infection include low socioeconomic status, having other STIs, using non-prescribed drugs, and having multiple sex partners. The presentation and prevalence is pretty classical for this Trichomonas vaginalis. So patients will present with itching, vulvar itching, vaginal itching, irritation, pain with intercourse that is new to them. They have a frothy malodorous discharge, and when a speculum exam is done, as we see in the picture, there's redness of the vulva, erythema of the vagina. They might have some stippling of the vagina and the cervix, which we call strawberry cervix. Prevalence, the prevalence is not accurately documented because we don't have a national, it's not a nationally reported condition, but of note, vulvovaginal Trichomonas genitalis is one of the most prevalent non-viral STIs. It's prevalent also in HIV-infected patients. So if you look at the breakdown, about 3.7 million persons are infected with Trichomonas vaginalis, and 1.8 are non-Hispanic whites, while 13% is found in non-Hispanic blacks. And the next slide actually shows Trichomonas vaginalis and other vaginal infections among women. This is a CDC. This is the CDC data looking at the initial visits to physicians' offices in the United States from 1966 to 2014. We can see that from 1966 to 2014, the prevalence of Trichomonas vaginalis has gone down and then become stable, while other vaginal infections are way much higher. So what is the natural history of Trichomonas vaginalis? 70 to 85% of patients might have minimal or no symptoms, and Trichomonas vaginalis could persist in the vagina, or if it's left untreated, for years. So sometimes patients might ask, is it my last partner or my new partner that gave me Trichomonas? But it can persist in the vagina for years. It's associated with increased risk of HIV infection acquisition. It's been associated with preterm birth because it leads to a lot of inflammatory reactions. Also, it's led to other adverse pregnancy outcomes like preterm, premature rupture of membranes. And the natural history is well depicted right here to my right, where we see an infective stage, and a diagnostic stage. So most of the time, we'll see that under the microscope, you see the protozoa, which is flagellated, as you see in this picture. So who should be tested for trichomoniasis? Symptomatic women. Any patient that tells us, oh, I have vaginal itching or I have vaginal pain, should be examined to make sure that they don't have an infectious vulvovaginitis. Also, asymptomatic women who are at risk, patients that have new partners or whose partner has multiple partners or they have multiple partners, patients who are HIV positive or have history of other STIs, commercial sex workers, and patients who inject drug or have a history of injection drug use. These patients are at risk for trichomoniasis and should be treated. What is the rationale for treating? The first is to relieve symptoms, to help the patient with the vulvovaginal itching and the copious discharge and pain. Also, it reduces the risk of preterm labor, preterm premature rupture of membranes, and of course, low birth weight. Also, treatment of trichomoniasis helps to reduce HIV shedding in HIV-infected women, hence reducing the transmission of HIV from HIV-positive partners to HIV-negative partners. How do we make a diagnosis? Diagnosis could be made in the office using wet prep or saline microscopy. Diagnosis could be made using a point-of-care testing, like the Trichomonas rapid test or the vaginal DNA testing. And diagnosis could be made using culture or PCR. So if we use a wet prep or saline microscopy in the office, the pH might be alkaline or it could be variable. It could be alkaline if there's a co-infection with bacterial vaginosis, then it's greater than 4.5, or it could be variable. The whiff test is negative unless there's bacterial vaginosis also co-infecting the patient. Saline microscopy, we normally look at times 10 and then at times 40. And what we see is mobile protozoa with flagella that is moving around. Sometimes we might not see the protozoa, but abundance of white blood cells should make us suspect that there's an inflammatory reaction going on. Because sometimes microscopy can have a low sensitivity as low as 50%. The vaginal PCR using an assay that detects the RNA for transcription is pretty sensitive, from 95 to 100%, and specific from about 95 to 100%. Culture is usually also positive, but I will want to recommend that once the sample is collected, it should be put in some saline, because if it dries out, we might have a false negative result sometimes. How do we treat Trichomonas vaginalis? The recommended treatment is 2 grams of metronidazole orally in a single dose, or 2 grams of tinidazole orally in a single dose. And an alternative treatment is to give metronidazole 500 milligrams twice a day by mouth for 7 days. This is also the dose that is recommended for HIV positive women. Pregnancy and breastfeeding. For pregnant patients diagnosed with Trichomonas vaginalis infection, is still the same 2 grams in a single dose. Of note, metronidazole, as we said earlier, crosses the placenta, but we have no evidence of teratogenicity. But pregnant patients should avoid tinidazole. No adverse effect has been noted in infants whose mothers breastfed and took metronidazole, but some clinicians or experts will advise that they should defer breastfeeding or pump and dump for 12 to 24 hours after taking metronidazole for trichomonas. What are the treatment considerations? Patients should avoid alcohol for 24 hours after completing metronidazole or for 72 hours after completing tinidazole. Their partners should be treated, and they should avoid sexual intercourse of all forms until patient and partner are treated, preferably for a week, to make sure that the protozoa has been eradicated. Retesting is recommended within 3 months. And if patients have resistance to metronidazole or tinidazole, they will need to be referred to an ID specialist. If a patient has an allergic reaction to the imidazoles, desensitization can be done to allow the patient use metronidazole. Trichomoniasis is one of the vulvovaginitis that the partner needs to be treated. The partner must be treated, and a single dose of 2 grams of metronidazole by mouth will suffice. Abstinence, as I said, until therapy is completed, is recommended. That way, the partners don't reinfect themselves. And not just the current partner, it's recommended that their previous partners should be treated, especially if the patient does not know how recent she contracted trichomoniasis. What is the role of rescreening? Patients with a diagnosis of Trichomonas vaginalis should be retested within 3 months. In a study that looked at 119 women that were positive for T. vaginalis at baseline, of the 100 that were tested 3 months later, 16.5 still tested positive for Trichomonas vaginalis. Is it possible they were reinfected or they did not take their medication, but it's important that they should be rescreened within 3 months of taking the treatment? Thank you very much, and I'll hand over for our education and counseling of the patient.
Thank you very much, and that was a terrific overview of the important components of vulvovaginitis. And now we're going to move to one of the most important aspects of treating and dealing with your patient who has vulvovaginitis, now that we've discussed the etiology and treatment. Aside from actual treatment, this aspect of care can make an important difference in the patient's outcome, both for the current episode as well as for her future. Counseling for the current episode provides an important window of opportunity that may impact on the woman's overall reproductive health, especially related to her risk of future episodes and her risk of acquiring a sexually transmitted infection. So in thinking about counseling, we consider how we set the stage for the counseling, being an active listener, and using the teach-back method. And as we set the stage for effective communication, there's some basic principles for communicating effectively that we need to consider, such as making sure, of course, we know the purpose to help our patients reach the decision that is best for them, and this is especially true when there are various treatment options. That we present the information in several ways, whether it be a verbal method, whether we use numerics for those who like to see everything in graphs, graphic presentation, and in our multicultural, multi-ethnic communities that we live in a language that she can understand. We have to remember that being an active listener includes demonstrating our own interest with making sure she understands, whether it be through our body language, our eye contact, and our facial expression. We need to eliminate internal and external distractions, which can be a real challenge in today's world of caring for many patients in crowded settings, and to make sure we try to understand what it is that the patient is really concerned about or worried about, and that we repeat whatever questions the patient has asked us, and that we make sure that we hear what her concerns are. So in terms of being an active listener, we may want to ask her what questions she has about her vaginitis, and always remember to take a pause, because sometimes the woman is not able to answer our questions very quickly, or may not answer at all. When she does speak and ask questions, that we make sure we understand the question and ask for clarification. As with counseling for any health condition, active listening to the patient is the basic tenet. And often it requires, as I said, setting the stage so that she feels comfortable talking about it, and always remembering when it comes to vaginal infections, often it is an issue of embarrassment for the woman, and we need to really help to make her feel comfortable talking about it. We need to listen to her story and help to reiterate, and maybe even try to generate from her what her most of her concerns are and her fears about the type of vaginal infection that she may have. And again, in a busy schedule that everyone is involved with, this may be very difficult to achieve, but oh so important in the success of working with this individual patient. So when we think about the teach-back method, we can provide important information as we teach back to her as the common cause of her condition, but focusing on those behaviors that likely contributed to her specific condition. For example, if it was antibiotics that may have resulted in candidiasis. You may be the first person to hear that the patient is having repeated infections, and possibly you may even pick up that she possibly could have diabetes as a result of the candidiasis. So again, active listening and listening to the patient and teaching back to her may open up the doors for learning even more about her overall condition as part of treating her vaginal infection. Counseling about side effects and dosing with the prescribed treatment is essential, especially since you hope your patient will continue the full course of treatment that you might prescribe. Informing her of potential side effects will help to ensure that she completes the full course of treatment. And given that you likely will be treating women with childbearing potential, many of whom may be using a contraceptive, it's also an important window of opportunity to counsel about any potential interactions with the treatment or the importance of maintaining her contraceptive. This means that we have to be diligent ourselves about reading labels and understanding the interaction of any drug that we might prescribe and how these drugs might affect, whether it's hormones or other medications that she might be on. It's also important to remind your patient to follow up with you, especially if she hasn't improved or her vaginitis has returned. So in terms of key counseling messages for vaginal candidiasis, most women have vaginal candidiasis at least once in their lifetimes, and some may have it frequently, and sometimes a longer course of treatment is needed. And for some women, I think it can be very reassuring to know that she is not alone, but that she's among many of her friends and relatives who also most likely have had vaginal candidiasis. For trichomoniasis, which is a sexually transmitted infection, the importance of having their sexual partner treated, I think, is extremely important and one that needs to be stressed. And for bacterial vaginosis, on the flip side, counseling that this is not a sexually transmitted infection, but is sexually related and can be related to other types of sexually transmitted infections. Of course, the use of condoms is very helpful, and this cleaning of sex toys is highly recommended, particularly in the case of bacterial vaginosis. It's also important to be able to provide your patients with educational materials, and hopefully these are available in your various offices or clinics. There are many different sources of educational materials, as you can see on this slide. Again, because we live in a multicultural world with multiple languages spoken, it is important and very much appreciated if there's access to written materials in the first language of the patient. And taking into account the health literacy challenges of most individuals, even those who are highly educated, helpful materials are written at a 6th grade level, if not a 4th grade level, and contain pictures that can always help to educate. One source of FAQs on vaginitis is on the ACOG website. And again, educational materials really can help patients to better understand vulvovaginitis and to review what hopefully they've learned during their during their patient visit. And now I'd like to go over just a brief case presentation, share with you this particular case of Casey, who is a healthy 20-year-old college student who presents with burning down there. She has had 3 new partners in the past 3 months and only male sex partners, and also has a contraceptive implant that was placed 6 months ago. So the question is, how do we approach evaluation and management of Casey's symptoms? And in evaluating Casey further, she has an itchy, thin discharge, pain, especially with intercourse, and has reported irregular condom use. On exam, she has a thin, frothy discharge with vaginal erythema, and her lab results indicate that the pH is 5.5, her whiff test is negative. She has numerous white blood cells on wet prep, but no trichomonads are seen. Well, with that history, likely she has trichomoniasis. Her signs and symptoms are consistent with that diagnosis. But the wet prep sensitivity, as we recall, is only 51 to 65%. And if the sample has been dried out, it may prevent visualization of trichomonads. So the question is, what would we recommend in this particular case? The recommendation at this point would be to treat her as if a trichomoniasis is presumed, but importantly to test for other STIs as well. The recommendation of metronidazole, 2 grams orally in 1 dose, is what you would prescribe, reminding Casey, however, about the importance of avoiding alcohol for 24 hours after the dose. And this has to do with the absorption and the importance of the liver enzymes, both in the use of metronidazole in this particular case, and alcohol, of course, which goes through the liver. It's very important to test for a cure after treatment in this condition, to educate about consistent condom use, and to emphasize that partners need to be informed and treated, and to recheck Casey in the next 3 months. The retesting, of course, being an extremely important component of her overall care. So in summary, as we've listened to the various slides this afternoon, vaginitis or vulvovaginitis is common and certainly can affect the quality of life for women. It is vulvovaginitis, something that occurs and tends to reoccur for women, both in the reproductive years and can also occur in their menopausal years. BV and trichomoniasis can have adverse pregnancy effects, so it's very important to be on top of these conditions for those women who are anticipating that they might become pregnant or are planning pregnancies. Sexual transmission, yes, with trichomoniasis, no with candidiasis, but BV, while not being sexually transmitted, can be sexually related. Effective treatment requires accurate diagnosis, and one type may predispose to another. But again, vulvovaginitis, it may not be what you might consider an exciting topic, which many don't necessarily even have that much information about, but it provides an incredible window of opportunity to counsel and teach your patients about the prevention of STIs and pregnancy that will affect their entire lives. It's a window of opportunity for your patient's overall health. And from a research point of view, it's a field of great importance, opportunity, and excitement. What we're learning about the microbiome sheds light on the dramatic role of the vagina and its environment. And I urge you to join in the excitement of focusing on this field. And now I think we have time for some Q&As.
Yes, we do. Thank you so much, Ruth and Tosin, for that excellent presentation. And we are going to move on to some participant questions. I will read them out for you and either ask for volunteers or basically just say your name and ask if you're willing to field that question for us. First, from Gautam, we have a question about the new medication that you mentioned, which is, please tell us more about the risks and benefits of the new single-dose medication for BV. This seems like a big deal. Tosin, is that something you would be willing to speak to for us?
Sure. So the new drug is secnidazole, and the benefit of secnidazole is compliance. So it has a longer half-life of almost 17 hours versus metronidazole that is 8 hours. So it has a better compliance profile. And also it's well tolerated. In the phase 3 studies, it was well tolerated and it has a better compliance. So those are the main things about secnidazole.
Thank you so much. Let's see, we have a question from Linda, which asks, what are you doing for recurrent BV? And before I turn that over to one of our faculty members to answer, I do want to preview that we will be having a webinar focused on recurrent and non-infectious vulvovaginitis. Next week, I will provide some more information about that as we wrap up. So the question again is, what are you doing for recurrent BV? Who would like to take on that one?
So this is Tosin. Recurrent BV, recurrent bacterial vaginosis diagnosis at least 3 in 12 months. We can either try metronidazole 500 milligrams twice a day for 7 days with intravaginal boric acid 600 milligrams at night for 21 days. And we can do just a long metronidazole course of metronidazole 500 milligrams twice a day by mouth for 10 days. And once the patient completes the treatment regimen of metro or metro with boric, you can put them on metronidazole gel, vaginal gel twice a week for 4 months. There's a study by Jack Sobel, and the main side effect of twice a day for 4 months, 2 times a week, forgive me, metronidazole gel 2 times a week for 4 months is that it reduces the reoccurrence, but patients might have a higher episode of vulvovaginal candidiasis.
Thank you for that. I have another question here from Yenet, who asks, with what should sex toys be cleaned? Who would like to tell us about cleaning sex toys?
Well, this is Ruth. It's a great question, and I suppose it depends on what's available and what the toy is. But I would say start with soap and water, as with any other item. Whether you need something more, perhaps alcohol as well. I think the important thing is to keep it clean, keep the toys clean and dry, and in a clean place, and then to wash them prior to use.
Thank you so much. And Tosin, would you like to add anything or weigh in on cleaning of sex toys?
I mean, depending on the label, some sex toys, after washing them, like Ruth said, can be wrapped in like a saran wrap and microwaved for like a minute or two. So depending on what type, because you have to look at the insert. You can wrap it in a saran wrap and then microwave it for like a minute or two.
Okay, things that we learn in the process of talking about these topics. Wonderful, thank you. We do have some additional questions that we can certainly get back to folks about. Unfortunately, we are just about out of time though today. Again, I would like to thank Tosin and Ruth for joining us today and for all of the advice and input they have given us in developing this slide set.
As I mentioned earlier, we do have a second webinar coming up in this series. It will focus on non-infectious and recurring vulvovaginitis and will take place on Thursday, September 28th from 1 o'clock to 2 o'clock p.m. Eastern. As a reminder, you will be receiving an email from ARHP's Education Department containing a link to the post-test survey for this webinar. Your CME or CE certificate will be generated automatically at the end of the survey. Please be sure to print the certificate before closing your internet browser. If you have questions, please do email us at education@arhp.org. Thank you for taking the time to participate in today's webinar, and we hope that you will take part in other ARHP-sponsored activities again in the near future. Have a great afternoon.